Hey, gang, section 5. How is everyone doing today? Hope this video finds you all doing well. Really exciting week, you guys. I really enjoyed the conversations that went on this week, and I thought everybody had a lot of really good stuff to say. Maybe this was one of the reasons is because this really a lot of people have lots of comments. There's lots of interesting literature, lots of treatment options, but I really enjoyed this week's conversations. I thought it was really good. So quickly, getting in through some of the different topics that we talked about. The Kayabashi article, when talking about clinically relevant changes with abduction, external rotation, emphasis in open kinetic chain exercises in relationship to patellofemoral pain. I thought this was a really interesting article for a couple of reasons. First of all, I'm a big close kinetic chain guy, and these were open kinetic chain exercises. It was just TheraBand. It wouldn't, to me, seem like enough effort to make a big change, but it does. It was specific to a population, females with patellofemoral pain, but obviously this is probably the largest group of people. They saw sustained at 6 months, both at the WOMAC and the VAS, saw some fairly significant changes in both of those outcomes. Again, hits home the fact that it is perhaps not the train on the track, but the track moving under the train, the powers research, the stuff that was talked about, that Eric Robertson talked about. Really important to remember when we're gauging our exercise programs to our patients. The Collins et al. Article on the anterior knee pain, the kind of systematic review, basically they came away with this whole concept of multimodal approach that, multimodal, regional interdependence, this global perspective of treatment. But one thing I thought that was really interesting is that orthoses that they saw in their systematic review did not seem to change the treatment outcome, both short and long term, that there was one RCT that showed some positivity, but as a general rule, orthotics, and we're going to speak more about this when we get down to the foot as we go through the next couple of weeks, but orthotics, especially custom orthotics, which are really kind of the used to be, they're still very expensive and used to be used a lot, perhaps may not be as necessary. I always like to, from a research standpoint, this scatter plot, if you guys aren't familiar with scatter plots, looking at effect sizes in regards to where different research will see the treatment effect at kind of a null hypothesis, which is at 0. And in this case, you can see, I threw this up there because I thought it was a really good scatter plot to see the effectiveness. So 0 to 6 weeks, the 0 is no effect. To the left, -2, -1, effect sizes regarding a negative effect, and then positive effect would be going to the right. And so then we have this broken down with a confidence interval of 95%. You see this at the 0 to 6, 7 to 12, 13 to 26, and then greater than 26 weeks. And you can see that then it's really easy to look at the research and kind of just get a global perspective that that multimodal, if you look here at some of the multimodal MMP multimodal that treatment effect had the greatest one, and that some, there was some exercise that had some effect. We see some of the strongest one down here, that, electrotherapy, not really a big effect. And so scatter plots are a really great way to look at the effect sizes in relationship to the research and to get a kind of a global perspective. And I thought this was a really good one coming out of the Collins study. So the Dial article, Dial does great stuff down at Army Baylor. Gail Dial does some really good stuff. And this one was really no exception. Manual therapy and knee OA. Manual therapy for knee OA with exercise. I should have said manual therapy and knee exercise for knee OA was more effective, 2 times more effective than a home program. The question is it worth the cost? They pose that question in the literature, and I think that that's a really valid one, because not only do we have to look at treatment effect, but we also have to look at the cost involved. There's, the healthcare, there's only so much healthcare dollar out there for everyone, and we have to be very judicious in how we disseminate that money. And we can't just think that, hey, we're the greatest and we have great outcomes, and yet we're really expensive. We aren't, but I want to bring that up. And then they use viscosupplementation as a kind of an example. And, I think it was Katie somebody, and I apologize, I'm not getting this. Somebody's had a really great, posted an article that showed, maybe it wasn't Katie. The visco supplementation on average, a systematic review looked at, and it works about from 5 weeks to 13 weeks. And we know that exercise, and if continue to adhere to the program, can work much, much longer than that. And then with tune-ups, how much longer we can push that out. And that whole tune-up question is a really big one. And I think that there's going to be more research on that coming down the road. But, in my mind, this is very well worth your buck. And those visco supplementations, man, those are just Band-Aids, and they don't last very long, and they just kind of rile me up a little bit. And then this dial group that received manual therapy and exercise, they had increased satisfaction. They used decreased meds. Patient satisfaction is huge. That's what we want. If people are happy with what happens, then you're bound to have success. Fitzgerald's article on perturbation doesn't matter. It doesn't seem to matter. Although I did find an article that I used that I kind of have in my back pocket that compared balance training to exercise, and they showed that both groups did very well. And in this case, Fitzgerald was just looking at adding that perturbation training, and it didn't really show much difference. I think that, the bottom line is we need to get people to move, and maybe balance for knee OA isn't a huge deal, and maybe there's a subset of people who would really benefit from that. Maybe some people who are more involved, maybe some people who are older, maybe past the age of 75 or something like that. But as a general rule, overall, we shouldn't be just focusing on perturbation training. So, points of conversation. I just titled that this because there was some really good discussions that I'm not going to talk about because I just don't have time. And I apologize. I tried to pick out some ones that I thought were really pertinent, but there are other ones that I thought were really good that I'm not just going to get to. So that's why, while they're not necessarily, they're really good posts, not all of, there's more than just what I'll be talking about today. So in Alpha, Aaron and Casey had a great article on imaging and knee OA, and they were talking about some of the negative effects of when patients see their images and how that has a deleterious effect on their own view of their outcome. And I didn't get a chance. I didn't get into the conversation because they weren't my groups this week until late. But I would challenge them to remind patients that arthritic changes are a natural aging process. Some people have more, some people have less. That I cited, I did respond into their group. There's a video that Evidence in Motion has put out called Wrinkles on Your Face, and that arthritic changes are like wrinkles on your face. Nobody likes them, but they are, but they don't cause any pain. And research has demonstrated time and time again that arthritic changes are not indicative of pain levels. There's not a direct correlation before the more arthritis and more pain. And we just have to continue to hammer that home on those people to give them hope. In the Bravo group, Karen, Justin, and Ray are talking about exercise progression and the importance of foot control. I thought they had some really interesting concepts about maintaining intrinsic foot muscle strength, and I think that will come up later in our 8-week course when we're talking about foot stuff, and just exercise progression, open kinetic chain versus closed kinetic chain. Some of the research shows that open kinetic chain can be almost as effective. And believe me, I'm a huge closed kinetic chain guy. I push hard on that. I try to get all my patients in weight bearing because it's very functional. It reproduces exactly what their day experiences is. But the reality of it is that open kinetic chain has its place. And for those patients who can't tolerate some of that stuff, we need to make sure that we're giving them something to do and challenging them with that. Maybe more reps, more times per day, and so forth. Charlie, Ken, again, we talked about, Ken had a really nice point, I thought, about costs, and he posted this really good chart that I thought really summarized the costs associated with treating knee OA, and I wanted to highlight it because the cost effectiveness, you look at some of the costs of these things, and how much this is costs associated with a lifespan of knee OA. So oxycodone, $76,000. Weight loss programs, $11,000. That was another thing that we got into, a discussion about weight loss programs, the hydrochloric acid. Obviously, that's being used more than one time, with a total of $14,000. So people are spending a lot of money on knee OA. I guess that's really the take home. And what we offer certainly you're gonna spend some money when you work with us, but I think our lasting benefit is much stronger and ultimately we are cheaper. So in Delta, Katie, she talked about the importance of the whole patient. I really liked that as a neurotherapist, she finds value in orthopedic care. And I wish that orthopedic physical therapists found value in neuro types of treatments. And I think that we do, but this whole delineation of different camps, a patient is a patient is a patient. And that's how I responded to Katie, is that we need to see the patient as a person who can benefit from our services, not from a neuro service and not from an orthopedic service, but from a service of physical therapy. And I love the fact that she's willing to go in and get after some neuro patients with manual therapy, because I think they are grossly underutilized, and I think that there's some real gains to be made that are being missed out. I remember when I worked at the hospital a few years back, and I would always go in and use my manual skills on stroke patients, on obviously people with acute low back pain, on some of the just deconditioned patients and some of the spinal cord injuries. They always benefited, and they always were very thankful that I had used some of those things that they had not been exposed to. And then Matt talked to, there was a discussion about home exercise compliance and changing ways, changing habits. I posted an article about how exercise, there's some research out there that talks about why knee OA people aren't compliant, and kind of how we have to worked hard to get that compliance and to get patients to buy in. And if they don't, it becomes really challenging. I also posted to Katie a nocebo presentation that I had done as part of a bigger presentation on placebo, nocebo, the words we use, and empathy. And I posted the nocebo presentation in week 4, in case anybody else wanted to look at that when talking about kind of how we speak to our patients and the words we use and how impactful that they can be. Lastly, so in summary of week 4, we had a great week. You guys did really well. We move on to week 5, which is ligamentous and articular cartilage disorders. We're going for new groups. I don't know what I was thinking last week in talking about new groups, but we're going for new groups, and we're going to keep the fellows and myself in the same group. So Jess and Hallie will be still with Alpha and Bravo, and I'll be with Charlie and Delta. But we're going to switch all the groups up, and I'll send that out on Sunday. We're going to add an extra discussion topic. There's a really interesting blog by Roger Carey that's being passed around and getting a lot of buzz about what we are as a profession and what we should be and what we shouldn't be. And it's creating a lot of controversy, and hopefully you guys will get a chance to read through it. It's not a very long read, and I think it might spur some really good discussion. Nesting discussions. Continue to nest your discussions. I appreciate everybody doing that. I know that we're still a couple of people who are having a hard time with that, but when we mix them up this week, we'll mix up Bravo and we'll hopefully get them back with other people to kind of show them the way. Midterm grades, I'll be handing those out. I'll be sending you out emails. I hope to have them done no later than Monday night. So that you guys can know where you're at, and then we'll, like I said, when we get in these new groups and our group projects, we'll want to get going on those fairly quickly. So I hope you all, if you have any questions, please feel free to send me emails as soon as you can, as soon as you think about it, because I can get back to you and we can solve any problems that you might be having. Other than that, I think you had a great week this week. I appreciate all your efforts, and I hope to see and hear more a good discussion for week 5.